What's up, everybody? I'm Dr. Garrett Rossi at Shrinks and Sneakers, and I'm a board-certified psychiatrist making mental health content here on YouTube. And if you're new to this channel, I would love to make you a member of the community. It really helps me to know that this information is valuable for you and that it's helping you to make informed decisions in your everyday treatment and life. And if you're a returning viewer, thank you so much for your support. So in today's video, I'm going to do what many viewers have asked me to do in the past, and that is compare two antidepressants or compare one antidepressant to other antidepressants and say which one is better and when would I use this medication over another medication. So the medication that we're going to be talking about today is Vilazodone, and we're going to try to answer the question, is Vilazodone any better than other antidepressants that are available on the market? So if you're interested in that, stay tuned because we're going to cover all the details on Vilazodone. So I'm excited to tell you guys this story because I'm going to tell you pretty long story here that dates all the way back to 2001. So in January of 2011 though, the FDA finally approved Vilazodone for the treatment of major depressive disorder. So it's only approved for major depressive disorder, and that approval came in 2011 on the back of two randomized controlled trials that proved its efficacy and tolerability. But let's go back to 2001 for a second. So in 2001, there was a pharmaceutical company called Merck in Germany that had licensed Vilazodone to GlaxoSmithKline, another pharmaceutical agency. And in April of 2003, an interesting thing happened. The rights for this medication, Vilazodone, were actually returned from GlaxoSmithKline to Merck because there were phase 2b clinical data that did not support progress to phase 3 clinical trials. So this is really interesting. So the company that ended up buying the licensing agreement initially gave it back to the original company because they didn't feel like the data indicated or warranted a phase 3 trial, and they were concerned it wasn't going to get FDA approved, essentially. Now, subsequently, several other companies actually acquired the rights to this medication, and there was one pharmaceutical company that completed the phase 2 trials and phase 3 trials and eventually got the FDA approval, and they were able to launch Vilazodone into the market in 2011, as I stated before. Now you can imagine that this is a bit concerning, right? Because here we are talking about a medication that almost didn't come to market back in 2003 when the rights were returned to Merck at that time, but it passed through a couple different hands. Maybe some different data scientists worked on this, and ultimately it came to market in 2011. So we're going to dive into Vilazodone, how it works, what are the side effects, how does it compare to other antidepressants, and I'm going to answer all those questions here in this video. So let's start with what separates Vilazodone from other medications, because I think that's always important. One of the things that people are constantly asking me about is, well, these new medications, they're so exciting, so many different mechanisms, different ways of treating depression. And then ultimately you see like the mechanisms aren't all that much different, they're kind of the same. And I'm going to explain what separated Vilazodone and what the rationale behind it was. Because what's really important for me to do for you guys here is to explain why they were thinking that this was such a revolutionary concept. And I'm going to explain what they were thinking here as a pharmaceutical company and drug design and all that stuff. So Vilazodone is part of that new generation of serotonin modulating medications. Now I've talked about them before. This could include things like vortioxetine, and if you haven't seen my video on vortioxetine, I would definitely encourage you to do so because it's an excellent video that covers all of those details as well. So Vilazodone is this new generation of medication. Now, of course, it works by two different mechanisms in general. In this case, it's stimulating serotonin receptors, and it's also blocking the reuptake pump, which is the traditional way that most antidepressants work. Most block the reuptake pump of either serotonin or serotonin and norepinephrine. So it has the traditional mechanism plus this other stimulating property where it's going to be modulating, let's say modulating, I don't know if I want to say stimulating, I'll explain why in a second, but let's just say modulating other serotonin receptors. Now the primary mechanism of action is actually quite simple. It's a serotonin reuptake inhibitor, and it's also a 5-HT 5-HT1A receptor partial agonist. So you might be saying, what does this mean? Dr. Ross is kind of crazy. I don't really understand all this partial agonism stuff and everything. Well, like I said, the blocking of the serotonin reuptake pump is normal, and that's like a standard method or mechanism of action in most of these medications. But this 5-HT1A receptor agonism, partial agonism, is a little bit different. Now, this medication is not considered a reuptake inhibitor, and that is because the affinity for the 5-HT1A receptor is much higher than the affinity for blocking the reuptake pump. So let me give you guys the theory about why they thought partially agonizing 5-HT1A would potentially make antidepressants work faster. So this medication was largely developed based on a theory. So like all good theories, you have to test it out and make sure it proves to be true. So this is based on a theory that traditional antidepressants have a delayed response, right? We know that we usually tell our patients it takes at least 2 weeks to start seeing any improvement, and sometimes it takes 4 to 6 weeks, or in the case of things like OCD, even 12 weeks. So it takes a long time for antidepressants to work. And the theory was that this delayed response that was occurring was related to the 5-HT1A autoreceptors. Now, autoreceptors are going to be located presynaptically. So autoreceptors are going to be on the presynaptic terminal, and whenever, and specifically they're located, these ones are, a lot of them are located rather, are in what's called the RAF-A nuclei. And the RAF-A nuclei is the primary serotonin production in the brain, primary serotonin producing center in the brain. So there's a lot of these autoreceptors on these serotonin neurons in the RAF-A nuclei. Now, when these are stimulated, so when serotonin is released, it feeds back onto those autoreceptors, and then, like all feedback mechanisms in the body, especially if you've studied endocrinology, it's going to reduce the firing then of those serotonin neurons, because essentially it's a signal to the body saying there's too much going on here, there's too much serotonin, we need to pump the brakes. So it's going to feed back on itself, it's going to decrease the activity or inhibit those neurons, those serotonin neurons from firing. Now, this stuff is really high level neuroscience and is probably a little complicated for the average viewer, but if you're in medicine or you're just into neuroscience, it's pretty cool stuff. But you don't necessarily have to worry about it, but that's why the company thought this was really important to utilize this mechanism of action. Now, efforts have been made for years to block these 5-HT1A autoreceptors by other pharmaceutical companies and other drugs as a method to decrease, again, the onset of antidepressant activity. So we want antidepressants to work faster, and to do so, the theory is that blocking or partially agonizing these 5-HT1A receptors might do that. Now, keep in mind that in the presence of excess serotonin, a partial agonist will actually act as an antagonist or blocker, which is the goal here. Remember I said the goal is not to stimulate these receptors, it's to block them and prevent serotonin from stimulating them. So what the partial agonism does in the presence of an excess amount of serotonin, say due to reuptake inhibition, it's going to block those receptors and prevent it from binding and allow those neurons to continue firing. So that's an important thing to keep in mind. Another important point I want to make here real quick is that the bioavailability, or how well this medication is absorbed by the body, is somewhat dependent on food. So you really need to take this medication with food, and you should always do that to make sure the bioavailability is maximized. Another important point I want to make in this section is that vilazodone is eliminated primarily through cytochrome P450-3A4 metabolism in the liver. And medications, of course, that are going to inhibit or induce cytochrome P450-3A4 will increase or decrease concentrations of the medication. So you have to be careful if you're on an inhibitor or an inducer and adjust the dose accordingly. So in this section, I want to briefly take us through the dosing of vilazodone. So vilazodone is available in a few different doses, 10 milligram tablets, 20 milligram tablets, or 40 milligram tablets. Now the recommended target dose is 40 milligrams per day, and that's with a starting dose of 10 milligrams per day for the first 7 days, followed by a titration to 20 milligrams per day for the next 7 days, and then up to 40 milligrams per day as your target dose. Now, studies have also looked at doses as high as 80 milligrams per day, and there is no dose adjustment required for anybody with either liver impairment and or renal impairment. So no dose adjustment is required in most cases unless the liver impairment is very severe. All right, so finally we're getting to the part that you guys have all been waiting for, which is how well does vilazodone actually work to treat depression? Because that's what we really want to know at the end of the day, right? How well does this medication work, and how well does it compare to medications and treatments that are already available on the market that are often much cheaper? Now, the efficacy of this medication that led to FDA approval was demonstrated in 2 8-week placebo-controlled trials. So there were placebo-controlled randomized controlled trials, and there were participants in the age range of 18 to 65 in both of these trials, and they looked at a scale in order to determine whether or not the person had a response to the medication or remission. So they were assessed based on a standardized rating scale. And the first trial had 410 individuals, and they were all started on 10 milligrams per day of Vilazodone for 1 week, and then titrated to 20 milligrams per day for the second week, and then 40 milligrams per day for the remainder of the study. So again, total of 8 weeks, randomized controlled trial comparing medication versus placebo. They had 410 individuals in the first trial, started with 10 milligrams per week, went to 20 for a second week, then up to 40, which is the target dose for the remainder of the study. And at the end of the 8 weeks, the Vilazodone group showed a significantly better response, and that's going to be defined as a 50% reduction in symptoms, and total score on the screening scale, or the scale that they were using to measure, 40.4% versus 28.1% in placebo. And remission rates in this study were actually not reported. So the response rates were very good. They beat placebo significantly. They were statistically significant. However, the remission rates by this group were not reported, and the statement made by the authors of the paper was that they were not statistically significant compared to the placebo group. So they weren't statistically significant or different than the placebo group when we're talking about remission rates. And that's important because remission is ultimately what we're all after, which is 100% reduction in all symptoms. No symptoms at all is what you're looking for. Now, they did a second trial to obtain FDA approval, and this was conducted for the same 8-week length, and they did the same titration schedule. So they did 10 milligrams for a week, 20 milligrams for a second week, and then 40 milligrams for the remainder of the study. This one had slightly more participants, 481. And in this case, approximately 14% more patients in the Vilazodone group were responders. So again, 50% reduction in symptoms, 14% more in the Vilazodone group compared to placebo. So the response rates were 44% in the active treatment group and 30% in the placebo group. Now again, remission rates were not significantly different between those taking the medication and those in the placebo group. So they actually did report their remission rates, and their remission rates were 27% in the active treatment group versus 20% in the placebo group. So again, not significant enough difference to necessarily say that remission was more likely to occur in the group receiving the medication. Now, this does not mean that it wouldn't have separated at some point. What this really tells us is that the number of participants was too low to see a statistically significant difference. So there was a difference. 27% of people who were taking Vilazodone achieved remission in 8 weeks at the 40 milligram dose, and 20% of placebos achieved remission. So this doesn't mean necessarily that it doesn't work or that they wouldn't have achieved remission. It just means that there weren't enough people in the study, and the study wasn't conducted for a long enough period of time. Now, the part that you guys are waiting for is, were there any head-to-head trials? And what we mean by head-to-head trials is this is where we take Vilazodone and we put it up against escitalopram, for example. Or we take Vilazodone and we put it up against vortioxetine. Unfortunately, I was unable to locate any head-to-head trials comparing Vilazodone to other antidepressants directly. So nobody's done these studies. There's an open area of research potentially for somebody to do. What I was able to find was a couple of indirect comparisons. So there's one indirect study that I found from 2016, but it doesn't tell us much about how Vilazodone compares to other medications. The conclusion made by the author was more about tolerability, and specifically looking at tolerability of vortioxetine, which was one of the medications in this study, compared to the other medications studied. So it really wasn't necessarily talking about the medication we're talking about here. I did find another article from 2017 that was able to directly compare Vilazodone versus citalopram in a systematic review and network meta-analysis. So they were able to at least compare Vilazodone to citalopram, but they also had other medications that they were trying to look at too, including Vilazodone and vortioxetine. Again, and they have similar efficacy and tolerability to other second-generation antidepressants. So again, the conclusion by this author in this case was the same thing, which is that, hey, it's tolerated about as well as any other antidepressant you choose, and also it's about as effective as other antidepressants that are already on the market and that are much cheaper. So unfortunately, there's not a lot of great head-to-head data. We can't really say definitively, is this better than other antidepressants? It doesn't seem to be from the preliminary data that I read, but again, those studies have not been done and have not been carried out appropriately, so we can't say that definitively. Okay guys, so let's talk about side effects for a little bit, because that is something that we all want to know about, we want to be informed about when we're making these decisions to take this medication. And you might be saying to me, Dr. Rossi, well maybe this medication is a better option for some people because the side effect profile is better. And you might be right about that. It might be beneficial in that case, and we'll talk about the specific reasons why. So Vilazodone's safety and tolerability was evaluated in 2,177 total participants with major depressive disorder. And overall, from that 2,100 or so participants who were in these randomized controlled trials, overall 7.1%, so 7.1% of participants discontinued treatment due to some type of adverse reaction. And that was compared to placebo, which there was 3.2% of people who discontinued in the placebo groups. So 7.1 versus 3.2. As expected, the classic things that we see with other antidepressants are the main side effects that were reported. Things such as diarrhea, nausea, and headaches were the most common side effects reported. The side effects primarily occurred during the first week of treatment, and the incidence of headache actually wasn't that much different from the placebo group. So for example, there were headaches found in 13.2% of those taking Vilazodone, or I'm sorry, 13.2% of those on placebo, and 14.2% of the ones taking the Vilazodone. So about a 1% difference in the development of headache. Another important thing that was noted from these studies is that there were no significant EKG changes at doses up to 80 milligrams. So again, no significant changes at doses up to 80 milligrams in EKG, such as prolonged QTC. And there was no effect on weight gain. So most people did not gain weight on this medication. There was no effect on weight gain from baseline. So that was another important thing. Weight gain is always an issue with psychiatric medications, and we want to be careful not to cause excessive weight gain in our patients. The other point and the other major thing I want to talk about here is sexual side effects, because that was another place where this medication really shined, was that there was a significant reduction in sexual side effects compared to other medications as well as placebo. And the most reported problem associated with sexual dysfunction was a decreased sexual desire. Now, Vilazodone does carry a black box warning for increased suicidal thinking, especially in patients under the age of 24. This is common on all medications, pretty much all antidepressant medications. And there are no trials of Vilazodone in pregnancy, but it was not teratogenic in rats or rabbits. So again, in animal models, not shown to be teratogenic, but there's no large-scale pregnancy studies, so we don't really know if it's safe, and it should not really be continued or started in women who are pregnant or nursing, unless they're already on the medication. Again, the risks outweigh the benefits. That's a clinical decision that would have to be made. And also, I want to point out that Vilazodone is not recommended in the child-adolescent population at this time, so you will not be seeing this FDA approved for children under the age of 18. All right, guys, I'm going to wrap it here. I'm going to do a little wrap-up for you, a little bottom line kind of information for you to know. So at this time, we don't know if Vilazodone is any better than other available medications, especially cheaper alternatives that have been around much longer and are now available in generic formulations. So we really don't know because the head-to-head trials have not been conducted, as I said previously. There is some evidence indicating, though, from the meta-analysis and review articles that I presented earlier, that it's really no better in terms of efficacy or tolerability than other medications. So really, it doesn't have any benefit in terms of being more effective in the real-world scenarios or in the randomized controlled trial setting, and it doesn't really have that much of a significantly better side effect profile that the tolerability is much better. Now, it may be a good option for somebody who is at severe risk of sexual side effects, or they absolutely cannot tolerate any sexual side effects, then this might be a good option for you. It's unlikely that the sexual side effects alone would be enough to recommend this as a first-line agent just because of the cost and for the fact that it's not any more effective. And this goes back to something that I've been preaching to you guys since the beginning, and that is that medications that are new are not always better. So the new shiny flashy thing doesn't automatically make it better just because it's a new thing and some novel mechanism. At the end of the day, what we do know is that newer medications have a better side effect profile and are more tolerable, and the older medications have better efficacy. So what you are trading off in tolerability, you're losing in efficacy. So you have to ask yourself as a patient when you're making that informed decision, what do I want? Do I want an effective medication, or do I want one that's tolerable that doesn't have as many side effects? That's a question for you guys to answer. With that said, I'm holding it there. If you guys have questions or comments, drop them below. It really helps me to know that you guys are interested, and I'll try to answer them as fast as I can. Obviously, my life is super busy, so I try to do the best I can. All right, so take care, guys. See you next time.